At this moment, I would like to welcome back Dr. Russell Chabanne for his second lecture that's going to be on intracranial pressure monitoring.
I would like to thank the organization committee to give me the opportunity to talk about intracranial pressure monitoring. Here are my disclosure. This lecture is largely inspired by this review from Gregory Areluk and colleagues recently published in Intensive Care Medicine. Injured tissue frequently exhibits hemorrhage and edema, increasing its volume. The injured brain is uniquely challenged because it is part of the skull where compartment syndrome develops. Focal pressure increases within the skull can precipitate herniation of brain tissue, while generalized increase can impede the inflow of nutrients. This is why measurement of intracranial pressure played an important role in clinical care for more than 50 years. Although cerebral swelling and the consequences of opening the skull were understood by Galen and Hippocrates, the modern understanding can be traced to Kelly and Monroe. The Monroe-Kelly doctrine holds that because the brain is enclosed in a non-expandable skull, when the volume of an intracranial component increases, compensatory displacement of blood and cerebrospinal fluid occurs. When this compensation is exhausted, a linear increase in volume leads to an exponential increase in ICP. Measurement of CSF pressure in humans started in the late 19th century with lumbar CSF pressure measurement. CSF pressure was considered to be a reliable indicator of ICP. This provided the rationale for measuring ICP directly within the skull. Early description of such intracranial measurement came from Guillaume and Jani in 1951 by Houghton of Clermont-Ferrand, France, as well as by Nils Lundberg in Sweden. Lundberg described eponymous A, B, and C waves of ICP, which remain fundamental aspects of brain pathophysiology. A waves are synonymous with plateau waves in which intracranial hypertension is sustained for 5 to 20 minutes, while C waves reflects influence of the cardiac and respiratory cycles. B waves are short repeating elevation in ICP with a frequency of 0.5 to 2 per minute that are of uncertain origin and relevance. The principal reason for ICP monitoring is the toxicity of intracranial hypertension. Indeed, ICP elevation is not merely a marker of injury severity. Without treatment, acute intracranial hypertension may be rapidly fatal, either because of transentorial brain annihilation and brainstem compression, or because of critical cerebral perfusion pressure reduction, leading to global ischemia. Patients may suffer different doses of high ICP, which reflect both the magnitude and time of exposure to intracranial hypertension. The impact of these ICP doses on outcome has been studied in different series. Prolonged ICP values higher than 20-25 mm of mercury were associated with unfavorable outcome and mortality. This is also informed by studies on decompressive craniectomy performed for refractory intracranial hypertension. When decompressive craniectomy is performed and ICP surgically controlled, mortality is reduced, providing further evidence of the lethal potential of prolonged ICP. The same concept applies also to subarachnoid hemorrhage. Nevertheless, the long-term effects of high ICP on functional outcome of survival remains less clear. Less extreme ICP values, not immediately resulting in brain death, are associated with harm from impaired energy delivery to the brain, but ICP thresholds remains uncertain. The Brain Trauma Foundation guidelines stated that ICP should be monitored in all salvageable patients with a severe TBI, defined as a Glasgow Coma Scale score between 3 and 8 after resuscitation, and an abnormal CT scan. An abnormal CT is one that reveals hematomas, contusions, swelling, herniation, or compressed basal systems. ICP monitoring is also indicated in patients with severe TBI with normal CT. if 2 or more of the following features are noted at admission: age over 40 years old, unilateral or bilateral motor posturing, or systolic blood pressure below 90 millimeter of mercury. The International Multidisciplinary Consensus Conference on Multimodality Monitoring recommendations are relevant to a broader neurocritical care patient population. ICP and CPP monitoring are recommended as part of protocol-driven care in patients who are at risk of elevated ICP based on clinical and/or imaging features with strong recommendation and moderate quality of evidence, and can be used to guide medical and surgical interventions and to detect life-threatening imminent annihilation with strong recommendation and high quality of evidence. In fact, in other acute severe brain injuries, such as subarachnoid hemorrhage and intraparenchymal hemorrhage, indications for ICP monitoring are less formalized. Acute hydrocephalus in SAH patients should be managed by an external ventricular drain. Similar apply to spontaneous intracranial hemorrhage, where in presence of coma and clinical evidence of annihilation or significant hydrocephalus, consideration should be given to ICP monitoring and treatment with an EVD. ICP monitoring is more controversial in other conditions, such as meningitis or hypoxic encephalopathy. The SYNAPSE ICU study was a large international multi-center observational trial intended to investigate the current status of ICP monitoring in TBI, SAH, and ICH. It included 2,395 patients, 55% of whom had an ICP monitor. It documented large variability between centers and countries in the current use of ICP monitoring. In this study, ICP monitoring and treatment was associated with significantly lower 6 months mortality and better neurological outcomes in patients with at least one reactive pupil. Measurement of ventricular fluid pressure is the current gold standard for measuring ICP, as it is the most accurate, low-cost, and reliable method of monitoring ICP. This method permits periodic recalibration and therapeutic drainage of CSF. Major drawbacks of external ventricular drains are possible obstruction and that the external transducer must be maintained at a fixed reference point, the external auditory meatus. Changes in position of the transducer may lead to inaccurate assessment of ICP. Occlusion of the holes at the tip of the catheter can impede pressure transduction and result in underestimation of ICP. Moreover, this system allows accurate ICP measurements only when the ventricular drain is closed. Placement of EVDs can also be challenging when the ventricles are compressed or shifted. Although placement of the EVD is often seen as a minor procedure, it can be associated with serious hemorrhagic and infectious complications, as well as neurological deficits. The overall hemorrhagic complication rate is approximately 7%, with a lower risk of significant hemorrhage, nearly 0.8%. Catheter-related ventriculitis and meningitis are potentially life-threatening complications, ranging from 0% to greater than 20%, depending on the definition of the infection used and the characteristic of the study population. Intraparenchymal ICP transducer devices are of two types: devices based on pressure-sensitive resistors with piezoelectric strain gauge, or those that incorporate a fiber optic design. ICP probes are usually placed in the right frontal lobe at a depth of approximately 2 centimeters. The Pressio, Chabanne, and Romedic sensor are compatible with MRI, but the Camino contains ferromagnetic components. It is not possible to recalibrate them after placement, and although they are very accurate at the time of insertion, there is a degree of zero drift over time, which can result in a measurement error after several days. The overall safety of microtransducer-based ICP monitoring devices is good, with low rate of complications. Subdural and epidural monitors are less accurate than intraparenchymal devices, and lower ICP values are measured in the subdural than epidural space. Such monitors are rarely used in clinical practice. Although the gold standard for ICP monitoring is invasive devices, they could be associated with complications. Moreover, sometimes ICP monitoring is desirable but not definitively indicated. Non-invasive ICP estimation devices are based on morphological features such as MRI, CT, and fundoscopy, and some on physiological changes like transcranial and ophthalmic Doppler, tympanometry, near-infrared spectroscopy, EEG, or autoacoustic emissions assessment. Ultrasound-based method and automated pupillometry have the advantage of being safe, easily repeatable, and inexpensive. Sonographic measurement of optic nerve sheath diameter is a convenient, rapidly performed bedside technique which shows promise for assessing the presence, absence, and magnitude of increased ICP. The optic nerve sheath is continuous with the dura mater and therefore surrounds the subarachnoid space containing CSF. As the optic nerve sheath is distensible, when there is an increase in CSF pressure, the diameter enlarges. To date, different optic nerve sheath diameter thresholds have been proposed ranging from 4.5 and 6 millimeters. Transcranial Doppler is another promising ultrasound technique for the non-invasive assessment of ICP, and it also holds promise for non-invasive CPP measurements. Intracranial hypertension produces specific changes in cerebral blood flow velocity and waveform with diastolic flow velocity being particularly sensitive. Gosling pulsatility index is one of the first parameters derived from the TCD for ICP assessment. Other formulas have been proposed for ICP and CPP estimation. In recent years, automated pupillometry has seen increased use in the ICU. Different parameters have been evaluated, and among these, the neurological pupillary index, named the NPI, as a suggested association with ICP. In a cohort of 134 patients, Chen demonstrated that in a patient with normal pupil reactivity, the average ICP was 19 millimeters of mercury, whereas in patients with abnormal pupillary reactivity, the average ICP was 30 millimeters of mercury. Interestingly, pupil abnormalities were detectable nearly 16 hours before important increases in ICP, suggesting that NPI may provide early warning. There is also an inverse correlation between NPI and intracranial pressure, further supporting that pupillometry may help to estimate ICP non-invasively. Non-invasive methods are limited by high intra and inter-observer variability, the need for training, and a lack of standardized methodology. They are not yet accurate enough to substitute for invasive methods. However, this could be used when invasive ICP monitoring is not available or is contraindicated. The Last Brain Trauma Foundation guidelines have recommended ICP treatment thresholds of 22 millimeters of mercury. Although it is generally acknowledged that the ideal values is still not known with certainty. Indeed, values lower than 20 millimeters of mercury may be harmful, although there is also evidence that supra-threshold values can be tolerated. ICP monitoring can facilitate early detection of an expanding intracranial hematoma, or it can provide reassurance of normal values, which can be valuable when imaging or non-cranial interventions are needed. Moreover, ICP is needed to calculate CPP. Current evidence more strongly supports CPP-directed care than ICP-directed care. ICP allows the determination of the autoregulatory status. Cerebrovascular autoregulation is the process by which the brain's arterioles alter their caliber to maintain a constant nutrient supply in relation to change in systemic blood pressure, blood viscosity, the concentration of nutrients and metabolites, as well as other variables. The clinician should understand the important role that the cerebral blood volume plays in variation of ICP. Engorgement of the brain from autoregulatory mechanisms seems to underlie plateau waves. Rosner described vasodilatory and vasoconstriction cascades relevant to this process. Treatment which increase nutrient delivery to the injured brain can induce vasoconstriction, which reduces intracranial blood volume and ICP. When cerebrovascular autoregulation is active, ICP elevation are tolerated for a longer duration. Pressure autoregulation is the autoregulatory mechanism with highest familiarity and is depicted in the Lassen curve. Between the upper and lower limits of pressure autoregulation, cerebral blood flow remains relatively constant despite changes in systemic blood pressure because of changes in arterial diameter. This mechanism can be lost as a result of brain injury, and the brain becomes pressure passive. It is now recommended to include this evaluation in clinical practice as mean arterial pressure challenges in the recent guidelines. Different methods of assessing pressure autoregulation have been proposed, such as the pressure reactivity index, PRX, which is a running correlation coefficient between ICP and mean arterial pressure values. There is, however, no consensus on the accuracy, reproducibility, and clinical validity for the moment. An extension of autoregulatory principle has led to the notion of CPP optimal, which has been defined as the CPP at which the PRX is most negative. Currently, this approach is experimental with limited evidence. The notion of optimal CPP has also led to consideration that different patients could have distinct optimal ICP treatment thresholds. In addition, important is the notion of compliance, another metric that can be derived when ICP values are known. Compliance refers to the amount of the ICP increases related to a fixed increase in intracranial volume. Patients with poor compliance have less reserve and likely require higher ICP control. Analysis of the ICP waveform has long been known to reflect compliance, albeit with imprecision. Seattle International Severe Traumatic Brain Injury Consensus Conference, algorithm for the management of patients with ICP monitors and with both ICP and PBTO2 monitors, reflect expert opinion using tier-based algorithm to prevent and treat elevated ICP. Elevated ICP should be analyzed and integrated in an equation with ancillary monitoring, for example, motor and pupillar clinical exam, pupillometry, ICP waveform, or other to detect annihilation-related toxicity, and PBTO2, SGVO2, lactate pyruvate ratio, EEG, and other as multimodality monitoring to detect ischemia-related toxicity. ICP is then part of cerebral multimodality monitoring to personalize treatment. To conclude, ICP measurement remains essential to the intensive care of severe brain injury. ICP measurements and derived values are integrated in multimodality monitoring for personalized care. Further development of non-invasive techniques will improve safety and availability of ICP data. With many unresolved questions, ICP monitoring should remain a high research priority. I thank you for your attention.
We'll open the floor for questions.
I have a question for Professor Philippe. Philippe, Tu nous as dit que tu vas parler de NIRS pendant les questions. Alors, j'aimerais bien que tu en parles.
Bonjour, vous m'entendez?
Oui,
Do you hear
oui.
me? Can you hear me? Yeah, I was supposed to talk about the NIRS, but it was a short presentation, so I didn't have time to place the NIRS monitoring during my session, and that's why I said during the question. But my presentation, I'm not sure. Did you pass my presentation already or not?
Yes, we have.
Okay, because you asked me to log in at 11:15, so I didn't hear it, but that's fine. So regarding the NIRS, there are specific indications for the NIRS for anesthesia, and I think that the monitoring we are using for depth of anesthesia, depth of analgesia, and oximetry of the brain, it's interesting, but the question we always have is, am I going to spend the price for the NIRS placement or for the null placement or for the EEG monitoring? So EEG and null index or nociception monitoring is not very expensive, even if it has some price. Regarding the NIRS, if you want to use the NIRS properly and use bilateral NIRS monitoring, then the price, and I'm going to tell the price in Canadian dollars because I'm from Canada originally, so it's was about $100 for the bilateral NIRS evaluation. So it led us to use the NIRS less than we wanted because the hospital administrators say that it was a little bit too expensive to use it in a very wide population. Regarding the usage we had for the NIRS, we decided to use the NIRS mainly in different type of surgery. The first one was vascular surgery with the carotid surgery, because it was helping us to detect some ischemia of the brain during the carotid surgery. And if we could see this ischemia, we would tell the surgeon, please shunt the artery now, because you see that there is an ischemia on the side of the brain you are operating on. So we wanted to make sure that the NIRS was helping us to detect patients who would benefit from a shunt made by the surgeon at the carotid level. That was the first population we were using the NIRS in. For the second population we were using the NIRS on, it was the shoulder surgery in a beached chair position, because most of this population is an aged population. It's a population who is about, I would say an average age was above 70 years old for our population in my center. So we had to use the NIRS in this beached chair position to make sure that the patient didn't have an ischemia detected by the NIRS during the surgery and didn't have the poor consequences of intraoperative ischemia of the brain during the shoulder surgery. So these were the two main indications we were using the NIRS for the population. We did not do cardiac surgery in my center, but I know that the ICM, which is the Institute for Cardiac Anesthesia and Surgery in Montreal, the ICM hospital, is part of University of Montreal. And there they use the NIRS daily in their cardiac anesthesia practice, combined with the EEG monitoring and sometimes with the nociception monitoring. So that's my point with the NIRS. I have to say that more than a number, I think that the trend of the NIRS and the changes of the NIRS along the surgery are more important than just the number itself, because the baseline number of the NIRS on the right side and the left side is depending on the characteristic of the patients. So I would say when you place it, sometimes it starts at 80, 85, sometimes it starts at 72, and you just have to accept what it is when the patient is awake. And once you are under anesthesia, you just want to keep with a specific algorithm to act if you see the changes going up or going down. If it's going up, it's not very important, but if it's going down and if it's going down to very low values that you don't want to see, then you can act different ways. As I said, in the carotid surgery, if you see that the side of the NIRS monitoring on the side of the surgery is really going down, then you can truly act and say to the surgeon, please shunt and do something because the brain of the patient is at risk of damages. I don't know if it answers your question, but.
Thank you.
So I have a question for Dr. Chabanne. Thank you for your lecture. So we've seen historically for the type of anesthetics that we are giving to our patients who are undergoing endovascular thrombectomy. We all started with general anesthesia, and then we had some data that came out that said that no, we should do local anesthesia or MAC. And then with the new data coming in, including your body of work, it seems that a properly conducted general anesthetic and a safely conducted local anesthetic can both give us adequate outcomes. Don't you think that in the face of this new data coming out, we should maybe focus more on the other modifiable factors like the time to groin or the blood pressure management?
Thank you for your question. Effectively, the all recommendations were based on observational trials, which had a lot of bias, notably a selection bias, because a more severe patient was treated with general anesthesia and had poor outcome, but it was more linked to the stroke status before the thrombectomy. And in fact, there was a lot of hypotension, which is, as you say, the main problem. So now it seems safe to conduct a thrombectomy with general anesthesia, but we've got to be very prudent concerning arterial blood pressure, which is a critical factor. So it's why you need to use with general anesthesia systematic norepinephrine infusion to provide at least 140 millimeter of mercury of systolic blood pressure. And after this type of care, the outcome seems to be as good as with procedural sedation, or even better. And other outcome factors are important. It was demonstrated that under general anesthesia, the quality of the reperfusion was better. It could be linked to the immobility of the patient and the security for the interventionalist. So it's an important topic that could be related to the outcome. And we will try to demonstrate the superiority of general anesthesia with important clinical outcome, which will be the 90-day modified Rankin scale, which is the functional outcome in our trial that we will conduct beginning in 2025, that will nearly include 1,000 patients. So we have to demonstrate this the beneficial of this general anesthesia strategy, but the arterial blood pressure management will be very important.
Thank you. Do we have questions in the audience? So we'd like to thank you both. There doesn't seem to be any questions left. Thank you very much.
Thank you very much.
Thank you.